There are a few disorders in psychiatry. Lots of them are these recurrent illnesses.
Is depression growing in the States?
Absolutely. Our society and the way that everything is going on now, I think situationally does really contribute to the depression. And then the pressures of the American lifestyle. Electroconvulsive therapy, ECT, is still one of the best treatments that we have. Lithium is still one of the best treatments that we have, not only for bipolar disorder, but it's one of the only 2 drugs that we have that actually has evidence that it reduces suicidal ideation.
I didn't really even know what mental health was. It wasn't on my radar when I was in high school. I was getting more friends, but I was also partying, smoking weed, drinking alcohol hard. 2017 was like, I got depressed literally right as the year started. I was dangerous to myself and others, and driving high or rollerblading at high speeds because you don't feel fear or factor in risk. That unsustainable set of symptoms ramps up into just sheer destruction.
Mind your health.
Mind your health.
Mind your health.
Treat yourself. You got to mind your health.
We are excited to have today on Mind Your Health our friend Dr. Kevin Marra. David Burke, it's so much fun to have Dr. Marra here. I've known him for quite a while. He is a psychiatrist at HopeWay Behavioral Health. And I think psychiatry and behavioral health in general, because you know that's the area I love, are really, there's a lot of myths and misunderstandings. So thank you today for joining us.
Yeah, it's wonderful to be here.
Let's start a little bit about you, Dr. Marra. Talk to us about your background and education, etc.
Yeah, well, I'm born and raised in West Virginia. I went to the university there for undergrad. I started out as a physical therapy major, and
did you?
I did, yeah. And then switched to education for about 2 weeks, and then decided I wanted to go to medical school, originally thinking I was going to be a pediatrician. And when I got into my clinical rotations, one of the core ones is psychiatry, and walked on the unit one day, on the inpatient unit, and just saw a patient that was manic, and I thought she was acting. I could have sworn that she was a paid actress. And I came back the next day and she was the same. And I came back the next day and she was the same. And then the next week she was better and she was back to her baseline. And that fascinated me so much. I was raised by sort of inquisitive, compassionate people, and pharmacists.
You're talking about me?
Yeah. We were speaking earlier. My mother was a pharmacist, and she did all kinds of really cool stuff in addition to retail pharmacy. She switched over to clinical pharmacy, but she helped develop part of a hospice program. And I remember having people come over that were end of life and eat Christmas dinner with us, that type of thing.
What do you think is the biggest misconception about psychiatrists and psychiatry?
Yeah, I think the biggest misconception is that we just medicate everything, that we're there just to write prescriptions. And really, when you look at our training, we go through 4 years of medical school like any other physician. And then we have 4 years of psychiatry training. The first year is really internal medicine and neurology. So we're in the hospitals taking care of people in medical units and neurological units. And then we have 3 years of, 60 to 80 hours a week of taking care of people with both aspects of treating them with medications, but also psychotherapy. So we're trained in core psychotherapies, psychodynamic psychotherapy is one of them, as well as cognitive behavioral therapy. And we have significant supervision and education. And so we're really utilized because there are not a lot of us. We're really utilized in a general way as prescribing medications. But really, I think what most of us enjoy doing is a mixture of doing psychotherapy, prescribing medications, and just treating the whole person.
Well, that's what I see in my practice too, is the balance. Because I'm all about the medication. I can counsel people on taking, what time to take it and side effects and all that. But they need so much more than just the medicine, because the medicine is either just going to mask or it's going to help them, but they absolutely have to have that same, one-on-one relationship. How do you balance of time? How many patients can you see in a day? Because you can't. It's not I go to my GP and I'm in and out in 6 minutes, you know, what's a typical?
Yeah, it depends on where you are, and I think corporate medicine is kind of something that I really try to rally against. But where I work at HopeWay, we see people for an hour and a half on our first session, and at a minimum of 30 minutes every week after that. And so I always tell people it takes you about probably 10 to 12 minutes to actually talk with someone about a medication and are you having side effects and how is it working. I use the other time to ask them about what's going on with you.
And I want to talk about HopeWay, but before we do, I want to run back to what you said too about the way that you all collaborate medically. I think, if I'm not wrong, compliance and worrying about side effects, especially with psychiatric medicines, seem to be the thing I hear all the time. They get the pill, they take the pill, they say it doesn't work. I feel tired. I mean, how do you all deal with that from a psychiatrist's point of view, and then from a pharmacist's point of view?
So just real quick, it's not even just worrying about the side effects. It's real. A ton of them are loaded with side effects. So it's not that it's uncommon at all. It's very common. So the good news is most of those side effects go away over time.
Okay.
You can manage the side effects, tweaking doses, that kind of thing. But
so what I hear you say is it's educating. Is that part of what you do when you're talking to folks about medicine?
Absolutely. Yeah. If you kind of let them know what's going to happen or what's possible, then they're not surprised when it happens. And then if you have a realistic discussion of this is how it's going to help you, this is what you might expect as a side effect, it's up to you to weigh whether or not the benefits are outweighing the side effects. And one of the biggest problems I have is people won't come and tell you. They'll just stop it. And I'll tell them like, hey, if you just told me, we could adjust it. We could switch to a different agent. We have plenty of things that we can try. But a lot of times they just sort of reluctantly stop it, or they stop it because they're feeling better.
I was right. No, is that true? Talk about that. Tell us more about that.
Yeah, I mean, a lot of our illnesses are just recurrent illnesses. So, you might have this predisposition to have a depressive episode or to be anxious. And during these episodes, you might have a medication that really helps you along with therapy and other lifestyle stuff come out of it. But you're going to be at risk of having another one. And sometimes there are illnesses that, like bipolar disorder, that really require medications to be taken consistently throughout one's life, quite frankly. And there's a lot of medical conditions like that too. So sometimes people feel like, well, I'm better, so I don't need the medication. And they kind of lose sight of the fact that maybe one of the reasons that they are better is because of the medication.
Oh, and absolutely. It's not just psychiatry. It's, my blood pressure's fine. I don't need that medicine anymore. My diabetes went away because I'm taking the medicine. I don't need that anymore. And
No, exactly. Well, it is so interesting with medicines because I know I get a lot of people saying I'm much more creative on this medicine. Well, usually that's a substance. I'm much more creative on this substance, and yet the medicine dulls my creativity. Do you hear a lot of things like that perhaps, I know the brain is an organ and therefore I can get a physiological symptom, I can get a psychological symptom, and they're all real symptoms.
Yeah. Of course, I hear that. There are some medications that actually do dull some of their senses and that kind of stuff. It's just, again, it's that collaboration, that follow up with your physician to find out what's working for you. I don't want to give you a medication if it's not helping you,
right,
or if it's hurting you more than it's helping you. And that's what I tell my patients. It's like, let's work together in a collaborative way to figure out how to best help you.
All right, you two, then let's work together in a collaborative way. What is the role and the goal of medicines in the psychiatric field? What are you trying to do and achieve?
The main goal is to sort of completely resolve or have a remission of the episode or symptoms that you're treating. So if you're having a severe depressive episode, the goal is to treat someone with a combination of meds and everything else to get them to the point where they're no longer depressed.
So are we managing rather than curing typically?
Most of the time, yes. There are a few disorders in psychiatry that are sort of one and done. Lots of them are these recurrent illnesses. So it's treating the episode to remission and then managing and preventing future episodes.
Can you talk about is depression growing in the States? I know we just came through a pandemic and a lot of stuff was brought to the surface with the pandemic, but it just seems that as a society, we're more depressed.
Absolutely.
Is that true?
Absolutely. And I don't think that we're creating that.
So wait,
No.
right. So it's not situational anxiety or depression. Is it organic? Are we, Is it what's causing all this depression?
Well, I think it's caused by a combination of, there are these genetic and biological underpinnings of that. But I think our society and the way that everything is going on now, I think situationally does really contribute to the depression. What I meant by we're not making it up is we're not overdiagnosing it, or we're not trying to tell people they're depressed when they're not.
Exactly.
But if you look at how stressful our world is, where you have instantaneous, communication, you can't even sit still for 15 seconds without wondering what's going on out there. Pick up my phone, check it. And then the pressures of the sort of American lifestyle, and keeping up with the Joneses. And then you look at if you're in a corporate situation, it's like, well, we want 10% year over year improvement, and we want that next year and the next year. And at some point, there's a threshold, and people just get to a point where they can't handle it.
And this might be a time to kind of shift for a moment and talk about behavioral health and what HopeWay Behavioral Health, where you work, what it does, what it is and isn't.
Mm-hmm. Yeah. So I work at a place called HopeWay. It's a nonprofit residential mental health center in Charlotte, and we have a whole spectrum of treatment. So we say we cover the hospital to the home. So imagine that you're getting no treatment, and imagine that you're so severe that you're in the hospital. We cover everything else in between. So our bread and butter is the residential mental health unit, which is a 24/7 unit that it takes the place of a lot of the hospital. It may be a way to prevent someone from going to the hospital or stepping down from a hospiper.
All right, David, I have to say this. So here's what I get. Oh, heck no. I'm not going to the loony bin. They put me in the psych ward. They wear the crazy out. Well, be careful. You might go there. I mean, that's the stigma when people hear a behavioral health center. Do you get that? I get that.
Oh, absolutely.
Okay.
And the current state of psychiatric hospitalizations, if we can start with that.
Yeah, sure.
Is, that there are people whose jobs in a medical center, inpatient hospital, their job is to drive down the length of stay. Okay. From about 6 to 7 days to 5 days. Okay. So that's really what we're facing. There's insurance pressures. There's all that. So it's essentially a place where people go when they can't be safe. Okay. And it's absolutely needed.
And to say that again, it's a place where people go when they cannot be safe. So we're trying to just stabilize you.
Absolutely.
We're not treating you. We just want to get you safe.
And it is absolutely needed. However, it is not necessarily a place to go get treatment as far as understanding why did this thing happen, how can I, it's a place to get stabilized. It's the intensive care unit of psychiatry.
So it is a hospital. You're not going to have a lot of freedoms. Your job is to sleep and get better.
So if you think of it as the intensive care unit of psychiatry, if you don't have a step down from that, it's like taking someone in a medical hospital in the ICU and sending them home.
Oh.
And saying, see your doctor next month and go see this therapist once a week. And that just doesn't cut it. Yeah. So what we do is we step them down to an unlocked, voluntary, beautiful facility where they're getting real treatment. They're seeing psychiatrists, they're seeing therapists, they're going to group therapy, they're getting family therapy.
They're doing yoga. They're learning to eat healthy and cook in a healthy manner. They're doing horticulture, not to take away, but I think everyone should visit, because I think talk about quick destigmatization. I mean, when you see they're playing music, I mean, it's an amazing, yes,
African drumming, which is
exactly
phenomenal.
But it's an amazing opportunity to sort of test out the waters of the real world in a safe environment. Yeah,
because I think, unfortunately, everybody thinks of One Flew Over the Cuckoo's Nest.
That's right.
And that we're light years from that now to staff that wants to help, that wants to counsel, that wants to see you get better.
Absolutely. And if I could throw one thing in there about the One Flew Over the Cuckoo's Nest. Sure. This is a PSA. So, electroconvulsive therapy, ECT, is still one of the best treatments that we have. Now, we don't use it a lot because it requires a lot of logistical stuff. It's 3 times a week. You have to go undergo general anesthesia, but it is still one of the best things that we have. And unfortunately, that movie and some other movies kind of mischaracterize it.
So in layman's terms, is it like, Is it rebooting the computer? Is it
That's
control
one-
alternate C?
That's-
and it shuts down and it just restarts?
Yeah, I mean, that's one thought. There's some evidence, and we can kind of talk about the sort of fad term of neuroplasticity, which is really interesting. That it's kind of
Yes.
like rewiring the brain and the brain's ability to kind of grow and form new connections. There's some evidence that happens after a procedure.
So without going too far down a rabbit trail,
Oh, I
So-
love a rabbit trail.
you and I are,
Do it.
you and I are fairly close to the same age. Is a depressive brain look different than a non-depressive brain on either MRI or CT scan or something?
I think in connectivity, yes. If you used a functional MRI, you would probably see certain areas of the brain.
Listen to them talk. Connectivity. all
And
this good
functional imaging or functional MRI is where they'll actually look at metabolism or something like that by attaching like a radioactive isotope to something like glucose that the brain uses for fuel.
With that in mind, now that we know so much about neurobiology and we have all of these imaging studies that can be done, is it corroborating some of the theoretical things that you all thought about the brain and how it works? I know that separating brain and body, when I first started, you worked cognitively.
Yeah.
Okay. And now we oftentimes work bottom up. If we can get your body ready to learn, then we're golden.
Yeah, absolutely. It has reinforced some of the ideas that we've always known. Let me give you an example. Do you play golf?
Depends on who you
Try to
ask.
play
But
golf.
that's right. Yeah, I'm a golfer. I'm a bad golfer.
So if you watch professional athletes, golfers, basketball players, they have a routine, and at some point they'll stand behind the ball and they'll pause, or they'll stand with the basketball in their hand and they'll pause and look. They're rehearsing in their mind what their shot is going to look like. If you put them in a scanner, in a functional scanner, you'll see that part as if they were doing the act physically.
Really?
The
Yeah.
areas that are kind of going to be coordinating the shot
No.
are lighting up whenever they're thinking about it. Same thing with addictions, right? So whenever someone's shown a picture of a marijuana joint or
Right.
they're going that part of their mind that gets the reward from actually smoking it is going to light up.
Oh, so that's urges and cravings
Absolutely.
and things like that. I mean, we literally could probably sit here and talk forever and a day, but I do want to go back to HopeWay for 1 second.
Yeah.
Who is your typical patient population?
Sounds good.
Yeah, well, when we started, it was adults only, 18 and up. So 18, we've had all the way up to, I think we've had a 90-year-old there before too. So, we find that mixing genders and mixing ages and mixing diagnoses has been
Healthy.
really actually beneficial and healthy. So adults in the residential center is still what we do. In the partial hospitalization program, that's kind of when you come 5 days a week. You're getting kind of come to class, honestly. You're going to groups and all that, and that Debbie talked about. That we opened up to teenagers, and we also opened up that to teenagers with eating disorders. And gosh, what a need there is for the teenagers. You talk about we talked about the stress of people that are depressed, and I think we looked at adults, but goodness, the kids have a real tough time.
What's really interesting for me, if we're going to talk about kids and adolescents, is I've had a few of my folks come to HopeWay, and what's fascinating is when they come back, they're excited not only about learning the skills, because they realize they have agency over themselves, but they love educating parents, siblings, and they actually are practicing them because they feel better. I mean, we recently had a young adult together, a young woman, and it was the first time she ever felt safe to begin her journey to understand her history and how she wanted to show up to the world. So I think the things that can happen, even just unplugging and I wish everybody had the opportunity to go for a while and just sort of focus on themselves.
Yeah. I think people don't have to be in a crisis to benefit from that kind of stuff either.
Correct.
Right. So, it's the kind of the stuff that we teach there are sort of like basic wellness type of behaviors and ways to operate that would keep people healthy and prevent future episodes too. So.
Well, it's amazing how social media has played a role in that image of, I have to be 5'9" and 110 pounds, and we won't go into measurements, but it's the Barbie mentality,
filters,
correct? And
well, and one of my clients who went was a guy, a young man, and it looks different for young men. Okay, an eating disorder looks different, but it certainly can have the same negative impact on the quality of life. So where do you see psychiatry going in the next, this is sort of a setup because we chatted about it.
Yeah.
In psychiatry, in pharmacy in the next 5 years. I should say 2 years, shouldn't I?
Yes. Yeah.
One sort of disappointment, I think, in the last couple of decades with regards to psychiatric medications is there's not really been like a robust medication that's going to be a game changer come out. If you come and see me, I'm going to be prescribing medications that have been around for 10, 20 years, sometimes 30, 40,
Yeah,
50
you
years.
get
Yeah,
that.
I was gonna say, if you're going to go back to amitriptyline, it's 70 years.
Yeah, another educational piece here. Lithium is still one of the best drugs that we have, not only for bipolar disorder, but it's one of only 2 drugs that we have that actually has evidence that it reduces suicidal ideation.
Exactly.
So,
And I've been reading articles about lithium in smaller doses with the aging brain.
So here's how.
Look, be scared.
Yeah. So here's how the fads have kind of caught up and helped me a little bit. So they sell lithium and GNC in a formulation called lithium oronate.
Yeah, exactly.
So we prescribe lithium carbonate, which is in doses, the average strength of
I've got to compete against
How
GNC.
fun is this, right? I mean,
so here's the good news: we prescribe more reasonable doses, more adequate doses. They're not allowed to prescribe higher doses. Lithium needs frequent monitoring, but it's a fantastic drug.
So at 70, should I run to GNC and get a little?
I don't think it would hurt you.
Little
It's in our
something,
drinking water too.
Oh, it is?
Some of the evidence. So here's the evidence for lithium. One, they look at municipal water sources.
Okay.
And they're able to see that the correlation between the amount of lithium in the water is inversely related to the depression rates and to the suicide rates in that community.
So pull the fluoride, load up on the lithium.
So in strength of evidence, that's called cross-sectional data, where you sort of a group of people and you're comparing 2 things. You can't quite make a connection that it's causative. But in studies, especially in bipolar disorder, where they're going head to head with lithium and another drug, and they're looking at all kinds of symptoms, including suicidal ideations or behaviors, the lithium group has always reduced the SI, the suicidal ideation.
So the bad news about pharmaceuticals and psychiatric care is there's no money in it.
Yeah, you can't.
The manufacturers, follow the money. Everybody has heart disease. Diabetes rates are off the hook. They're going to go where they're going to get paid, and they're not going to make any money on new psychiatric drugs.
Yeah,
So that's the reality of. Now we briefly talked about AI.
Yeah.
Yes, AI is going to help with that.
Okay.
Because there's not going to be a chemist in a lab anymore adding, should I add oxygen here and a nitrogen there? The computer's going to do it.
Well, can I shift it from the pharmaceuticals then and ask you, what is the gold standard? Then where does talk therapy or somatic therapy fit in? Is it if I can balance myself medically, and create some kind of homeostasis, and then am I then more open to psychotherapy? Am I then more able to build skills or strategies?
Yeah, there's 2 answers to that question. One is if you're in a better state, you're in a better place to receive, the therapy or to explore things, and you're not just trying to like get out of bed or get through the day or not want to end your life.
Okay.
The second answer to that question is pharmaceutical agents. A lot of the antidepressants, they actually, similar to what we talked about with ECT, that it will sort of prime the brain to rewire.
Got it.
So there are chemicals or growth factors in the brain that have been shown to be elevated when you take a medication. So that's like fertilizer for the brain. And think about your nerve cells and the little dendrites as
BDNF kind of?
BDNF, exactly. Brain-derived neurotrophic factor. Look at her pulling out the...
You just read it yesterday.
Yeah.
But I read it.
Yeah, so BDNF is kind of a popular growth factor they talk about, and that's essentially like miracle grow for your nerve cells.
Okay.
And so the idea is that you prime it there, and then if you engage in healthy behaviors, you routinely do things that are healthy, you form these really nice connections.
So here's what we've done today.
We've covered a lot of ground.
Yeah, we've covered a lot of ground. And the name of the podcast is Mind Your Health.
Mm-hmm.
And I think that what we've learned is whether we're minding our health through our brain or through our body, they're all very much intertwined, and there's a lot to learn. And we could sit here and go on and on and on. I love a good rabbit hole. So do you. But we're going to say thank you to Dr. Kevin Marra. We really appreciate you coming in.
Thank you.
And we hope you all really enjoyed this segment. What we're going to do with Dr. Marra is we're going to have one of his patients come in and chat a little bit as a lived experience of what it's like to take medicine, be on medicine, and some of the things that, the good things and the challenging things. So stay with us. A lot more to come here on Mind Your Health.
Awesome. Thank you.
Thank you.
Mind your health.
Got to mind your health.
Mind your health.
We are back here on Mind Your Health, and we have Dr. Kevin Marra, who's a psychiatrist with HopeWay Behavioral Health, and we also have Matteo Esposito, who is a recovery coach, a peer specialist, and also has a 501c3 Invisible Challenge, where he is focusing on destigmatizing mental illness and promoting mental health. So thank you very much for joining us. And we thought it would be fun and fascinating, informative and educational, Matteo, to actually, with your permission, speak with you a little bit about your experience in kind of navigating your own journey through mental health. Because let's just say you've been healthy for how long? Sober for how long?
2.5 years as of yesterday.
Awesome, man.
I mean, I'll do one of those.
All right.
There you go.
All around.
So let's just kind of talk a little bit, if we can get you started and jump in, about your how all this began. Do you mind taking us back from there? I know you did a TED Talk, so really just kind of the beginning of that.
Of the spiral.
Yes, as he calls it so lovingly.
Geez. I would say first thing that comes to mind, and what I kind of talked about in the TEDx, I would say just stress and a lot of moving. Basically, I didn't really even know what mental health was. It wasn't on my radar when I was in high school.
Right.
Definitely had ADHD, and I kind of knew it, but I was getting straight A's. I was doing well in school. I was doing well in athletics. Graduated high school, played junior hockey in Western Canada with my brother, which was awesome. And then for my second year, I got cut, traded, had to quit because of injury. And then by the time 5 months had gone by, I lived in 4 homes.
Ugh.
Torn labrum, had to go home. We had moved, didn't have any friends local, couldn't do anything physically, really. That turned into sleeping until 1, 2, 3, just had no energy, didn't feel like doing anything, but I didn't know. And then I basically escalated out of that by visiting my brothers in college, which was helping. It really, objectively, was helping my depression. I was getting more friends, but I was also partying, smoking weed, drinking alcohol hard, and staying up late.
What's so funny when you're saying that, I'm watching Dr. Marra over here going, like he's.
Let me say something.
He's controlling himself. But I think just listening to that sort of introduction, what is the takeaway just quickly psychiatrically from what you heard, or just medically or as a person?
Yeah, the medical term or the psychiatric term is stress diathesis. And that basically is this sort of underpinning of what we can get into your genetics or the predisposition that you'd have for mental illness. But then you're really illustrating the stress that you went under as a young adult, and also your age at the time. We know that these illnesses come out around, 18, 25 years old for men.
Did you feel yucky?
Yes and no. It was, I wrote this in my letter, which I want to talk about too, that I put out when I had a year in recovery, sober, whatever you want to call it. And then the TEDx as well. 2017 was like, I don't even hear that year. Like I hear 2022 or 2015. Okay. Like when I hear 2017, I have like a visceral reaction because of how big of a spiral and, my massive shifts in mood and energy levels and sleep. I got depressed literally right as the year started. And that drinking and partying I talked about ramped up into a bipolar 1 manic episode.
So talk to us about that. When he's talking about what he was experiencing with partying and no sleep, talk to us about how those specific conditions can exacerbate or bring on an episode. Is that what I'm calling it?
Absolutely. Yeah. So bipolar disorder is a disorder of mood episodes. So everybody knows what depression looks like. What distinguishes bipolar disorder from major depressive disorder is the presence of mania. Mania is like a really excitable, duration period of time, usually more than a week, where people go and they literally don't have any sleep, if maybe just a little bit of sleep, but they operate the next day and the next day and the next day. Their speed of thinking is so sped up, their impulsivity, they're really pleasure seeking, so they might be really engaged in substance use or sex and that type of stuff.
Okay.
And it's a really, really disruptive state.
Yes.
Well, that's the interesting part. Even I've one experience, but also read like hypomania, which you'd probably explain better than me, even though I have lived it. As far as I understand and have felt, it's the pre-phase to mania. So bipolar 2 disorder typically will not see mania, the full-fledged heightened mood and lack of sleep and full energy. So I have read that pieces of hypomania, which is sort of a not as destructive and a pre-phase to mania,
Is he doing?
He knows what he's talking about.
are actually sustainable theoretically if you could keep those symptoms like slightly higher energy and a little bit of hyper focus and maybe not 2 hours of sleep, but 6 or 7 and operating at a very high level. The tricky part is, I guess, to answer your question earlier, did I feel yucky when I was depressed? Yes. But when I started, I still remember the first day I felt a hypomanic symptom and it's euphoria. But then that unsustainable set of symptoms ramps up into just sheer destruction because it's almost hard to describe when you feel good and it can be that destructive.
And I know I'm kind of guiding you and shifting, but I want to make sure that we cover everything as we're talking. And I think my next question is, at what point did you feel, or did your family feel, or physician feel that it was time that you needed some help?
To begin, I didn't even know. I literally, again, I guess almost finding a podcast on bipolar disorder would be useful if someone's listening, but I didn't even know. Like I was gone. I had lost touch with reality. So when I got hospitalized because of risky behavior, I wasn't suicidal, but I was dangerous to myself and others, and driving high or rollerblading at high speeds because you don't feel fear or factor in risk. So when I had those feelings, I wasn't even like sad when I got put in the hospital because I had lost touch with reality. Whereas my family, operating as they do now, had to watch all that. So it was the peak of the manic episode. And when I had seen doctors for a broken wrist and I started medication, they were basically like, "You're not going to leave here."
That lack of awareness is one of the trickiest parts of mania. That you know, the person that's experiencing the mania feels great. Yeah, at least in the beginning.
You want to do what with me?
Right.
Are you kidding?
And a little sort of tidbit about our the way that we diagnose things. So that the diagnostic and statistical manual of mental illness, the Bible of how we diagnose things. Every single disorder in that book, in that diagnostic manual, has the caveat that it has to be cause dysfunction. Yeah. Right. So we don't call something a problem unless it causes dysfunction.
That's right.
The only thing in there is hypomania. Hypomania does not have to have dysfunction. In fact, many people find that their function improves. So what if I told you that you could sleep less, you had more energy, you felt good?
I'd like to order that.
There you go. The problem is, as you've come to learn, is that is a precursor to this full-blown episode he's talking about.
Oh, so let's talk a little bit about going to treatment, and then
I wanted to get there too. Actually, how we met each other.
Yeah, how do you all know each other?
To cut you off quickly, that was like very much like you asked at the beginning. 6 years later, it had continued to spiral in different ways, sort of got a grasp on the mania and the depression. And then, as I say in my letter, met a monster named addiction, which was definitely a battle, but that's sort of to fast forward to treatment.
Are they co-occurring often?
Absolutely.
Okay.
Yeah, absolutely.
Because initially, just to be transparent, I think all felt as though it was more of the symptoms looked like a bipolar condition that was symptomatically shown by your substance abuse, right?
For sure.
But
they definitely went hand in hand.
Right. But you kind of felt, and that's where you all were working together, that really addiction, before you could do anything, You felt like you had to get your addiction under control.
Yeah. And I've been told that by multiple psychiatrists, or at least the ones I've trusted the most and who I felt had the most knowledge. Let's treat the substance use disorder first, then the co-occurring mental health conditions. But it's not an easy task, as we both know.
Yeah. What do you think about that?
Yeah, I mean, you try to tackle them both, but I absolutely don't think that if you focus on one without focusing on the other, that you're going to get anywhere. One of the problems with bipolar disorder and substances, even cannabis and certainly stimulant medications, the medications themselves bring out that particular mania piece of that. So there are plenty of people I see that are young now who I don't know if they have bipolar disorder or if they just had a reaction to the cannabis that they were consuming.
Because it's not like the old days.
It is, yeah. We can have a whole other podcast, about that. But the PSA there is that the stuff that you're getting. Well, don't use cannabis as a PSA, but the gummies and the vapes and things like that you're getting in states that don't have full legalized cannabis is just we don't know what it is, but it's not good.
Yeah.
So what finally? Let's talk a little bit about the day that you talked to Matteo, and basically what kind of transpired. Is that okay with you?
Yeah. So I guess fast forward to give a hopefully brief timeline from 2017, which can be summarized, or I guess in a wavelength, as severe depression, 3-4 months of severe mania with a hospitalization, and then the worst depression I've ever had following that. Through kind of figuring it out for a year or two, and abusing substances, so relatively figuring it out. In 2019, I got diagnosed with a heart condition. I had felt it and tracked it for a year. My pulse would skyrocket when I would get high. The more weed I smoked, or the stronger the edible or gummy, the higher my beats per minute went. And it scared me, but not enough. And then I wore a tracker and did all these tests, and they're like, hey, this is really dangerous. The cardiologist said you can have a heart attack.
And he wasn't sleeping.
Well, at the time...
Ish.
Yes, but so I was like, okay, whatever. I'm not going to do this anymore. And then 2.5 months later, I did. And that kind of opened my eyes like, whoa, this could be a problem. And that went on for another 2.5 years, on and off. It wasn't the first time I had been to treatment, but I kind of had a bender of a weekend and just said, hey, I pulled the plug. I can't do this anymore for the second or third time. And I went to HopeWay in October of 22.
You were at Clemson. I'm testing my memory. You were at Clemson, weren't you?
I was. That's impressive.
Partying at Clemson.
Yeah, I was. That's an impressive memory.
But it ends up, I think, with, and I don't know if this is common or not, but basically it was, Matteo, this is from you. And I'm going to just start it and say, Matteo, we got 2 choices here, and I'll let you take it from there. He was talking to Matteo.
Yeah. Matteo, I think, well, first of all, I think, and I hope that it illustrates the relationship, the importance of a relationship. You felt comfortable reaching out to me when you had continued to use, and you had a point where you had an experience when you were high that was very scary. And it was at that point that my clinical judgment told me, you need to go to treatment now.
And after HopeWay.
After HopeWay.
Right.
And I remember giving you a bit of an ultimatum, there's this place I can send you for treatment, or I have the ability and actually I'm required to force you to go there, because I don't believe you are able to make the types of decisions for yourself that are going to keep yourself safe.
And I have to say, in addition to that, it was Dr. Marra on the phone. I was on the phone, and Matteo's best friend was on the phone. And what I found really interesting was that a friend, and this is really important, I think, for all people, to have a friend that can look at you and say, you know what? He's right.
Yeah.
Okay. I am not going to be your friend and sit here and watch you kill yourself anymore. It is time for you to do something about it. And I know we could go on. And again, this is another one we can go down a rabbit hole and tell 2.5 years worth of stories. But I really think the bottom line here is to talk about the hope. You came out the other side. You all have stayed in contact. You've created Invisible Challenge. What is an overall message for or from both of you about treating mental, do I say treating mental health? Treating mental illness? Treating substance abuse? How do we frame it? So,
Yeah, I mean, I want Matteo to answer that question. But
Yeah.
I say that broadly, there's another side to this. You don't have to live that way, and that other side is much better than what you thought it was.
Yeah. Honestly, my head is like you said, we can go on forever. So I have a lot of thoughts. But to that point, anyone who sort of asks me about it or wants me to get sober, and quite a few close friends have said like, hey, how'd you do this? I need to get on the other side. And like, a part of it does suck. Like getting sober, at least for me, was really hard. It was the hardest thing I've ever done when I really committed to it. And I was 6 months in, and debilitating anxiety, and I couldn't just go drink or smoke a bunch of weed and risk a heart attack. But what I say in summary is like, it's really hard. It was the hardest thing I've ever done, but it's worth it. That other side is worth it, but there's no script. It's just really hard to get to.
Talk to us about Invisible Challenge.
Sure. I think it's interesting because I feel like my answer to that, or to that statement, has changed so much over the last year or two.
Isn't it?
I think I guess to answer now, it's a growing brand, it's an idea, but I think the main point is there are two sides to every story, and it doesn't have to be mental health or addiction. My invisible challenge right now, or at the beginning of the podcast, I was nervous.
Okay.
Might be able to see that, but most people can't.
Okay.
My heart's racing still, but it was really racing when we started. My blood pressure's high, and I'm trying to just kind of stay calm and keep my thoughts together. Nobody,
Invisible Challenge.
and by invisible, obviously you literally can't see it, and it's a challenge because it's hard. And for bipolar disorder, if you meet me when I'm really depressed, I could go out and have beers and no one would have any idea. Or you could have crippling anxiety right now, stirring thoughts, just trying to keep it together, and we wouldn't know. Or you honk at someone on the road for not using a blinker, and their dad died 2 days ago, and they can't keep it together. So it can be anything. It doesn't have to be mental illness. And I guess the idea, or the purpose, at least right now, is to end the stigma. And while that isn't easy, when I say, hey, I'm going to treatment, I found it easier to just own what I'm doing. I wasn't like, sorry, I didn't respond. I didn't see it. I just said, no, I went to rehab and I'm sober now. And I find that makes a big difference by just openly talking, because I've seen people come to me and said, hey, like, thanks for sharing that. I'm going through this. Can you help me?
And not necessarily substance abuse. They talk to you about everything, because I think once they realize that sometimes challenges are invisible, we don't really know what we don't really know. Maybe it's empathy and kindness and listening and opening up discussions. I really appreciate you joining us. And I know we could talk for about 16,000 hours. But Matteo, thank you.
Yeah.
Dr. Kevin Marra, thank you so much. Thank you all for joining us here on Mind Your Health.
Mind your health.
Mind your health.